People who know the man who went on this rampage say it was totally out of character. Now, we should warn viewers, the footage is graphic. Maplewood, Minnesota. Surveillance video at St. John's Hospital captured a terrifying attack. A patient erupted in violence, beating several nurses with a metal bar pulled off the side of his bed. Police say 68-year-old Charles Logan just snapped, chasing nurses behind their station and bludgeoning them. At one point, some of the nurses tried to lock doors behind them to prevent Logan from continuing his assault.
Two of them actually fell down in the hallway, and they were repeatedly struck by the man with the pole.
One healthcare professional says this kind of situation is not uncommon.
That kind of thing can happen. Happens all the time.
Investigators say they're still trying to figure out what may have caused the nearly 70-year-old hospital patient to turn so violently against the very people who were trying to help him. Those close to Logan are clueless and say they're just as shocked as everyone else. As soon as he made his way outside, officers tried to use a taser to take him down.
While media attention focuses reports on homicides, not all violent acts like this make the national news. 74% of violent acts are occurring in healthcare and social services today. So where is the awareness? The mentality of healthcare is that violence in the workplace is acceptable and a part of what we do is just part of the job. Even with social media and everything bad that goes viral out there, workplace violence in healthcare is still underreported and underrepresented. You would more likely hear about a liquor store robbery and being held up and shot than you would about a nurse getting hurt during her normal duties at work. So even with social media, to keep us connected, the truth to me seems to be missing. I mean, have you ever seen on the news something like this where the nurse is assaulted? But you always hear about the other reports. I bet if you look at health grades reports, they don't reflect the disruptive physician who threatened the nurse in the OR. I have to admit that as I was looking for videos to use for this presentation, I was really shocked to see how many acts are actually caught on security cameras, and yet no one's talking about it. And obviously there's no shortage of issues out there for administration and risk management. But however, it seems to me that workplace violence doesn't seem to be even high on the list on a lot of healthcare organizations in putting together prevention programs. And I know you risk managers out there, you try to be proactive and determine the actual and potential incidents that cause risk every day. And unfortunately, the idea that change will occur when something catastrophic happens to someone in your organization is kind of the way that things move around healthcare. Just like anything in risk management, we start with increasing awareness through education. So today we're going to talk about the current state, and we'll go through some techniques and strategies and discuss some of the elements of even an active shooter response. There is so much information out there that today we will not be talking about everything. This is not an all-encompassing presentation, but I think it will give you a good place to start from. Someone's saying they don't have sound. Workplace violence in healthcare today. Let's set the stage for those of you who may or may not be aware. I think it's really important when you're developing a workplace violence program that you define it. Whether you use one of these organizations' definitions or some other one, it's a good starting point to make sure that you're all on the same page on where you want to take your program. There are types of workplace violence that exist. They put them into 4 categories, and basically type 2, 3, and 4 are ones that you're most likely to see in most healthcare organizations. You know, this is where you have the legitimate relationship with the organization and the patient, or it's an employer, more likely former employee who threatens a coworker, or even that perpetrator that does not have a relationship with the organization, but they're coming to take care of a patient and make them the intended victim. So where can violence occur? So while violence can occur in any healthcare organization in any setting, it's more frequent in the psychiatric wards, emergency rooms, waiting rooms, etc. These areas are the highest risk areas in healthcare, and I'm sure this doesn't come actually as any surprise to most of you. It didn't to me. I found these stats really pretty shocking, and I have been in healthcare for over 20 years, and I've worked in risk for a long time. And I've even worked in some of these high-risk areas myself. You know, the fact that 2 million American workers in general are victims of crime in a workplace is pretty stunning. And 70 to 74% occurred in healthcare and social service settings, with 10% of them involving injuries that took them away from work. Sadly, the healthcare industry leads all other sectors in the incidence of non-fatal workplace assaults, and of course, the emergency department is particularly vulnerable in this setting. More startling stats here. So half the nurses that have surveyed through the ENA study stated the hospital took no action. There needs to be a zero-tolerance policy across healthcare. After reviewing those videos, I was so frustrated to see how many acts of violence are caught on video, and nurses are still reporting that their organizations basically said it comes with the territory. Here we are in the business of taking care of patients, and yet we cannot seem to offer the same to those who care for patients every day. I thought this was interesting to just see how different states are trying to manage or not manage workplace violence. And you can see here that some require employers to run a program, but there's not many states that are doing it. Some have some laws, but there's quite the variation. What I found interesting here with these different states and their state legislation is if you read through it, an assault has varying degrees that whether or not they would be a felony or a misdemeanor or aggravated battery. And in Texas, apparently until recently, if you assaulted an emergency department personnel, it became a felony, but previously it was only applied to those who were out in the field doing emergency services that they considered it a felony. Not really sure why being out in the field and being in the hospital should be any different, but that's how the states look at it. So there's just not a lot of support out there. I think what's important to note here is that often healthcare workers do not think they have rights because they're only taught about focusing on the patient's rights. And this just feeds the mentality that violence is an expected part of the job. The Joint Commission's Environment of Care, if you're accredited by them, they do ask that you maintain a written plan, you conduct risk assessments, you provide strategies for preventing violence, and of course, you establish a response plan, and they also want to make sure you don't forget the rights and responsibilities of the patients. OSHA does not have mandated regulations regarding all workplace violence, but it has the general duty clause. So basically, there will be instances where you could get cited for failure to implement guidelines. It's not in itself a violation of the duty clause, but however, if there's a recognized hazard of workplace violence or they don't prevent or abate it, that is where OSHA would come in. And why the increase? Well, this is just from what we know, and many believe violence is seriously underreported. Today we have more psychiatric patients visiting hospitals. We have long wait times in our emergency departments in some areas. There's definitely been an increase in substance abuse. Of course, there's a lot of economic stressors. Gang violence is still there. And law enforcement sometimes having to keep the really intoxicated person at the hospital. I want to jump ahead now and get into some of the techniques and strategies that you can consider when developing your program. Approaching a violence prevention program is much like how risk management approaches other risk areas. So enterprise risk management, for those of you who don't know what it is, uses a process or framework for assessing, evaluating, and measuring all of an organization's risks. EMR then helps you quantify the risks to assist in prioritizing significance, groups them into components or domains, and then you look for interdependency and devise strategies to manage each risk across the enterprise. So ERM stresses the importance of removing silos to increase awareness through education and develop and implement processes that will ingrain good risk management behaviors into your healthcare settings. Under ERM, managers as well as your frontline staff would understand and promote a common goal, and it becomes incorporated into your culture of the organization, actually as a shared set of beliefs necessary to achieve the mission. So this makes you look at the HR department, the operations, the marketing group, your clinical group, and all the other areas, security, that are within a healthcare organization, and look at how something such as workplace violence would affect each area, and making sure that once you develop your protocols that you're not just drilling down into one area and forgetting about other possibilities. The components that I've outlined here are basically sort of the sub-areas that you would want to make sure you had in your written workplace violence prevention program. This is not an all-encompassing list, but this is one way to look at it. And this written program, it needs to adjust to respond to changes in the organization, expanding facilities, changes personnel. I mean, right now with the way healthcare is moving and a lot of organizations are buying up physician groups and employing them and extending their reach into rural areas, it's really important that you think about those other areas as well when you're developing your program. So management and commitment and employee participation, I think, is of the utmost importance. Having seen all those videos and listened to some of the interviews, and it's clear that a lot of your frontline staff in certain organizations do not feel supported. So if you assign the responsibility and the authority of the prevention program to make sure your managers and supervisors understand their obligations and make that known within your organization, that will help provide some support for your employees. Direct care workers in the emergency departments or mental health area may bring different perspectives to committee work. So I think it's really important that the range of viewpoints and needs should be reflected in your committee composition. You want to ensure the reporting, recording, incidents, all of that there's no reprisals. It's a non-punitive environment, or, just like how we discussed the need for a just culture. For reporting of other incidents, we need to do the same for workplace violence. People have to feel supported and safe to report without fear of repercussions. And I think oftentimes, too, we forget to have programs in place for the victims. So you want to make sure you establish a comprehensive program of counseling and debriefing for those who experienced or witnessed the assault. And this may need to go on for quite a while. Obviously, the repercussions can be long-lasting. You want to create those safety committees and talk about workplace violence at any and all safety and health committees where it makes sense. They should receive reports of the violent incidents or security problems so that they have the awareness. They discuss them at management meetings, making sure that everyone in the organization has knowledge about the topic. Make facility inspections mandatory. If you don't walk around your facility and know what's happening, you will have no way of preventing or trying to mitigate those risks that could put your staff in a bad place. And if you haven't started the conversation with the local law enforcement yet, now would be the time. Some of the suggestions that are out there that can be helpful as well is, providing them with a tour of your facility, as well as maps and badges to support a more timely and accurate response. So you put together almost a kit for them in the event that they need to enter the facility during, something that's violent is happening. You want to educate them on the types of incidents they might respond to. So while they're used to dealing with all different kinds of people out in the field, having the understanding that you folks have in the healthcare field and you educating them on that and some of the de-escalation techniques that might work for certain populations could be helpful. It also helps them to understand if they're walking into one area, they might want to approach it this way, or if it's a different unit or department, they'd approach it another way. And really make sure that they are collaborative with your security department. I know in the places that I've worked, our security department just were figureheads. I mean, unfortunately, they really did not do anything, nor were they given the ability to enforce anything. And when a violent patient or, sort of occurred in the emergency department, they weren't really able to help us control the situation, which, leads to your employees not feeling safe. Another way to gain that relationship with law enforcement is to do some non-emergency opportunities to interact. So have them come in and talk about seat belts. Have them come in and talk about other areas that they like to focus on while they have the captive audience of both your employees as well as patients. And it's important, do you meet with other external agencies to establish a standard response protocol because obviously this could get bigger than just your facility. It's important that you have that established within your community. I think, like with everything else we do in healthcare, we often forget to close the loop and bring the information and changes back to those most affected. So in order to really effectively communicate to your staff what the new recommendations are with corrective strategies and why you're doing this, you could do walk-arounds much like we do for other areas of healthcare. You could obviously use newsletters. If you have an intranet, you could post certain things on there within management and staff meetings. It could also be the beginning of every committee meeting where you spend 1 or 2 minutes on something related to workplace violence. You want to ask those employees and observe those employees in their daily activities to see what puts them most at risk for workplace violence. That way you can tailor the needs to those areas and making sure that you're helping to mitigate those problems. And you really need to ensure that there's a way to record your incidents and the near misses so that they can be addressed appropriately. Maybe you create a communication contact tree, so as the event is starting to escalate, certain people in certain areas know that they should slowly respond. You really need an incident reporting system that's accessible on every unit, on every computer, so you can capture more and people will report more. You can't just rely on memory from verbal reports. You need to do worksite analysis. So there are a lot of places where information is being collected within your organization. There are different types of records. There's job hazard analysis, medical records, employee surveys, patient-client surveys. So much information is being collected in a lot of different places. You want to be collaborative with your frontline staff and senior management and supervisors when you're conducting these analysis to really understand what you're looking at. It's always helpful to get some advice of an independent reviewer, somebody who has a lot of experience in this area, who can give you some objective feedback. And if you review your outcomes and you implement a workplace program, a violence program, and you are actually looking at the data and trending your analysis and you're doing this education and increased awareness, if you review those outcomes, those metrics, you should see an increase in the number of events reported to some extent, and a loss of workdays and restricted workdays should decrease. There are ways to measure the effectiveness of what you are doing. So how do you assess your facility? I thought this would be the most overwhelming part for most people as they're beginning on this journey. Even if you already have a workplace violence program in effect, obviously it's something you should be reevaluating on a regular basis. So the following tools on this slide and the next slide can help you conduct this very complex, multifaceted assessment. It's a little bit of subjective as well as objective. It actually comes from an excerpt from the American Organization of Nurse Executives and the American Nurses Association, which provides examples of analysis tools and links to other sources. So what I've done here is just shown you an excerpt of what they have provided in another document. And we will have a list of resources at the end of this presentation when we send it out to you folks. So don't worry about, trying to scramble and write everything down. One of the items they talk about is the Hayden's Matrix as being one way to identify it. Within the ENA's toolkit, they have a list of things to look at: staff, culture, and environment, to create your action plan. In Minnesota, it has a wealth of information and resources. They've spent a lot of time trying to promote education across their state. And one of the things that there's an example of is an actual healthcare gap analysis that they perform. And of course, OSHA's workplace, there's checklists and resources within there. Next, I want to talk a little bit about the analysis and trending. So you're reviewing your records, you're looking at your workers' compensation, your insurance, threats, police reports, you name it, you're gathering all this information. You really want to take the time to sort of track and trend it, and don't forget to include the near misses, because those near misses eventually will become actual events. You then can strategize. Take this data and determine your high-risk areas from your reviews and the aggregate data you put together. You can prioritize, and then you can develop interventions and programs. So for instance, a lot of folks have developed a violence rapid response team for their emergency departments, for behavioral health areas and other high-risk areas. In fact, what they've done is they've trained personnel in de-escalation techniques and to understand how to approach the patient and all the different areas that go into training. And it's a team that can then be called upon, much like a rapid response team for codes, and you can have them come to try to help decrease the situation. And I think, you know, one of the organizations actually is taking their behavioral health team and having them go to other parts of the hospital, because sometimes, obviously, your mental health patients aren't all on the behavioral health ward. And when that happens, you may not have staff who's really educated and feels confident in how to respond. So by having them come to the scene, hopefully you can mitigate that. Okay, I apologize for that. I don't know. It's the world of technology, and there's a ghost in my computer because it just completely disconnected us. So hopefully you're all hearing me again. Thank you. I see someone responding. Okay, where were we? We were talking about analyzing and trending and talking about the different types of rapid response teams. And that's just one way of really supporting those staff who maybe aren't going to be as comfortable in certain situations. Now, the Joint Commission has actually been tracking sentinel events that have to do with these criminal events. They've been doing this on rape, homicide, or assault only, though. And the category of sentinel events is consistently among the top 10 types of events reported to the Joint Commission. And since 2004, they've started to see a significant increase in the reporting of assaults, rape, and homicide, with the greatest number actually in like 07, 08, and 09 before this came out. So I've listed here some of the contributing factors that led to the event in some ways. So in other words, the policy procedure development wasn't there. Maybe the way they had implemented the program or not implemented their program. There were human resource issues, and that really has a lot to do with job descriptions, job competency, making sure those folks in those areas understand their risks and how to respond to them. So that lack of staff education and competency assessments was not happening. A lot of patients that were in observation protocols who maybe had behavioral health issues or some other things going on, there was a flaw in the way that they handled it. They just plain had inadequate assessment tools or didn't even evaluate for psychiatric issues. So these are some of those contributing factors that you can take into account when you're developing your program to make sure you have them in place. Now I'm going to switch gears a little bit and talk about other ways of reporting incidents. So reporting violence should be everyone's business. Much like how the Joint Commission collects and analyzes their incidents on violence in healthcare, everyone in healthcare should be doing the same. And it would really be best if it was through a web-based tool that's fast and easy to use. If you have a data collection tool for safety events as well as staff assessment surveys and all the other parts that we've started to talk about when developing your workplace violence program, and you house it in one central location that everybody has access to, that right there starts to help increase the awareness and education for your folks. And hospitals who have mandatory reporting policies, I found some statistics that show they experience half the rate of physical violence as hospitals without reporting policies. You increase your awareness and you increase your reporting rate. So here's how simple it can be. Was there a witness? What type of event was it? You click on workplace violence. You go through where it happened, some of the basic demographics. I mean, it doesn't have to be a lot. It's just enough for you to make sure that we go back to investigate it. This is an example of a disruptive behavior by a physician. I mean, as I'm reading through all these scenarios that go on, apparently, you know, some schedule change happened in the OR, and the surgeon wasn't happy with it, and he used some explicatives towards the nurse and then gave her the bird. I mean, so, but I bet she never reported that. So it's important that if you have a tool that's this easy, you will probably increase your knowledge of what's going on in your organization, even for the ones that don't make it up to the chain of command. And here it's easy. You have type of physical violence, where the weapons used. It makes it simple. Obviously, there's the employee safety security piece. Here's another example of how it can be reported with gathering your witness information, date and time. It would track the number of days off of work if you needed to. And here's another screen of what it looks like in our Healthcare Safety Zone portal when you're going to look at some of the highlights of the event. And in this particular case, the employee brought her fist and hit the employee. The patient hit the employee while she was trying to remove a blanket. So this is what it looks like after a report is filled out and a manager is trying to assess what the next steps might be. And then this view shows how a decision tree can be incorporated through trigger questions within the portal. And makes it so you really, all that data that, like the Joint Commission is collecting, you could be doing the same. And with this, you'd have a better way of approaching your interventions and prioritizing your focus on where you would want to put your resources to improve your program. Speaking of hazard prevention and control, another area that you want to think about is, that I mentioned a little bit earlier, is that analysis of job tasks or positions for specific areas known to be high risk. Do these periodic employee surveys that they have out there specific to violence. It can help you establish baseline tasks that are at risk, and then if you do it periodically, it will help you identify new or maybe undetected risk factors that were there before that weren't caught. The other thing that you could do is use EMR to flag patients with a violent history. A lot of folks are starting to use technology to help them. So, for instance, the EMR might have a screening list of 7 risk factors based on research, of course. And let's say the criteria is that if 2 or more are considered high risk, then that patient is flagged as being a high risk for violence. There's also the Brosette violence checklist. That uses more behavioral signs that you evaluate of the patient for any increased violence risk. But interesting, it is one of only 2 prediction tools that has been tested out there by randomized controlled trials out of 300 tools. So anyone who cares for potentially aggressive or abusive patients should be aware of the history of the patient they have in order to know what triggers to watch for. After an incident or near miss occurs, obviously you want to analyze the procedures that were or were not followed. And you want to identify, were staff adequately trained? And you could do this through competency questions, debriefing, interviews. And it's also important, again, I can't emphasize enough, that we have immediate support tools in place as well as delayed support tools in place to support these employees. Those immediate examples would be debriefing, time off work, a buddy assignment to make sure they're doing okay while they're back at work if they don't take any time off. Or delayed examples would be check in 1 to 2 weeks, do a formal debriefing. There's employee assistance programs. You might have on your staff folks who could do some counseling for post-traumatic stress disorder and some other, behavioral issues that might come out of this. And the reason I say assess staff education needs. By assessing their needs and providing the tools that maybe they did not have or did not use, you help empower them so that they can return to work and feel confident. There's always that piece of record keeping. I've talked about incident reporting. I've talked about the logs. But for those of you who may not be as familiar, as of January 2015, OSHA has changed some of the reporting. So they state that all work-related fatalities within 8 hours must be reported. All work-related inpatient hospitalizations that have to all amputations and all losses of an eye within 24 hours. But interesting, the only workplace violence that gets reported to them that has to be are injuries that are caused by assaults must be entered on the log only if they meet that above criteria. So OSHA's not really mandating all types of violence be reported here. Now, here let's talk about training, because it's probably one of the most important pieces of your program. There are a lot of elements that should be put into a training program, and here I've highlighted some of the more important ones. Obviously, you want your policies and procedures to reflect everything that you're doing, but education on the early recognition of behavior and warning signs is very, very important. They need that awareness of the risk factors, de-escalation techniques, and self-defense. I mean, it's really, knowledge is power here. They understand the availability of assistance, such as alarm systems and communication procedures. And you have to establish a uniform violence reporting system and plan. And you need to regularly review reports as part of evaluating and reevaluating the program to make sure that this is standardized and working well for you. You know, violence, unfortunately, should be thought of as expected, but it can be mitigated through preparation. So like anything in risk management training and education, increases awareness, it raises your overall safety knowledge, and helps staff address issues before they happen. That initial training really, really needs to be done before they're assigned their duties. So it should happen at orientation. And high-risk areas such as the emergency department and other areas are going to need a refresher maybe more often than annually. Probably the most important piece that's going to help your staff be prepared is the role-playing, the simulations, the tabletop exercises and drills. And I would say, you know, invite your law enforcement from your surrounding hospital communities. The presence of management at the training sessions can increase the visibility of the organization's top-level commitment to prevention. The involvement of that law enforcement, I think, is critical to the success. It's also an opportunity to educate staff on how police are going to respond and what types of things to watch for so that they can stay out of their way. And by having law enforcement there, it makes it more realistic to what it would really be like. You know, there's those risk factors that are important to address during training. You'll see this a lot in the literature out there that, you know, your acute versus long-term stay have different triggers. Obviously, feelings of helplessness or despair, which could just be about half our patients in organizations. Those who we know have mental behavioral health issues and are dealing with mental behavioral health services. Long waits in overcrowded areas, I mean, that's just, unfortunately, can be a place where that happens. I can't tell you how many times I had to go out in the waiting room and get screamed and yelled at by a parent who felt we should be moving faster in the emergency department and trying to explain why there was a system that, you know, unfortunately their loved one was not next. And some of the stuff that's said and done, you just kind of sort of have to take it because you don't want to react. So those overcrowded areas and long waits are definitely an area where people get upset easily. Now, this is just some examples of a basic de-escalation techniques that could be part of your training. This would be, you know, in response to disruptive behavior where there's, at this point, no threats or weapons. It's so important. I know this seems like common sense, but to respond quietly and calmly, and not everyone on your staff is going to be able to do this. So this is often why I was the one to go out to the waiting room. Because I didn't get riled in those situations. I didn't take it personally. You know, it's not a judgment against you. There are so many other factors going on, so you can't take it personally. You want to be respectful and show your concern, so asking questions, and you want to make sure you also have non-threatening, nonverbal behavior, and really focus on their feelings. I mean, more than for some of these folks, this is an emotional trigger that's causing it. This is for those, like I said, the lower level of disruptive behavior. Summarizing what you're hearing, reading, you know, saying it back so that they know that you're on the same page. Those challenging questions, you know what, it's sort of like with your toddler, you just try to redirect or move on to the next. It's hard to set limits, but if you have to, that you will need to do that. And, you know, sometimes you just have to allow for silence and allow for time for decisions and not feel like you have to keep talking. Sometimes that helps folks too. And that's just some examples. There's many more out there. You also have to think about the management of aggressive behavior, because with that you have to really train your staff for pre-event, in the event, and post-event scenarios. They need to understand how to use the duress alarms if they have them, or if they're wearing them, or if they're located in certain places. It's important, if you're going to have radio communication for certain areas that you're going to use when you feel that there may be a problem, you know, obviously you want to train them on how to use that. All patients with a risk of violence should have a plan that's coordinated by staff, and it should be assessed shift to shift. Obviously, you need to do education on the use of restraints, physical and pharmacological, you know, depending on the area you're in, that may be your last resort, but it tends to escalate the rage, so you have to really be skilled and be able to use that. And I would say take your online, put your de-escalation and safety techniques into an online education is great, but you really need to follow up with some classroom education and a focus on the demonstration. It's like anything. If we don't do it, we're going to lose it and forget. Risk managers are in the job of trying to predict the future. This is an enterprise risk management approach. You can't just drill down in one isolated area. You need to defeat those silos. You got to think about and anticipate all the contingencies and unrelated issues and what might be next. Now, I thought I would highlight some of the elements of an active shooter response plan. This is by no means all-encompassing. We would be here a lot longer than an hour if I was to do that. So, but I will share with you some interesting statistics. So apparently, 154 shootings occurred near hospitals, in or outside, over that 10-year period. But in the last year or so, we've had 14 active shooter incidents in U.S. hospitals, and 15 people have died. So you want to aim for getting that A for anticipating. The response time for police is generally like 5 to 8 minutes, and an active shooter incident, it lasts 6 to 8 minutes. You've got to be prepared. There was some literature out there and some information on some recent shootings in hospitals out east. And interesting enough, they had already required employees to do training annually. They worked really closely with their local police department. They trained actually in a new patient area before they occupied it. And they used a scenario that unfortunately or fortunately was very similar to what actually happened. So drills are important. They were prepared because they had already done all this. You could use vacant patient rooms or areas, or even something that's realistic location within your organization, so that when you're doing these drills, it feels like it would if it was actually happening. Because what I'm seeing is that a lot of folks are, doing like 1 to 1.5 hours of class time, and then they're doing like 2.5 to 3 hours of live scenarios. And when I say live, they're posting signs in their hospitals to say, hey, don't be scared of the noises you're hearing. We have a drill going on for active shooter, and they are doing drills in that right there within their facility in order to help prepare their staff. Another example you could use is paintball facilities. You could add firearm signs and metal detectors. Some organizations, depending on the actual neighborhood they're located in, and they may, be more inclined to use the metal detectors. Security cameras, of course, and panic alarms. Job descriptions, again, we've talked about that. Continuing education requirements and training criteria should be in there. And you have to think about the architecture. So if you're building a new facility, you might have someone come in who's consultant security who could come through and say, by putting it this way, you're actually putting your staff more at risk because they don't have a path out, or maybe if you did this, it would actually be better for your staff. it's worth entertaining this prior to building that new facility. We know policies and procedures should incorporate all the general guidelines that go with a workplace violence program. I mean, that should be everything, your prevention, your screening, your reporting, etc. You also have to think about address how and when to do lockdown, and that's where I think the professionals in the security industry and law enforcement are really helpful in how this should work, because they determine when that's appropriate, when it's not. You want to identify a common language to be used during incidents, as well as like special code names, code silver, code green, whatever you're going to call it. You have to make sure that you really make sure you train your folks on that standardized piece of communication. And your active shooter drills actually would fall under your emergency preparedness procedures. Oftentimes it is run the same way as other emergencies. You need a crisis communication plan. So for those who don't know what's going on and are hearing rumors within your hospital, you want that to be known. You want law enforcement agencies to be involved, and the media, and oh, by the way, don't forget that social media where everything goes viral. It's important that you have a procedure and know when to say all clear and who is in charge of saying it and determining it. And after the incident, again, you got to plan for those affected. So there may be some immediate emergency medical care that needs to be, provided, because obviously when law enforcement comes in, that first grouping that comes in, they're not there to take care of anybody who's gotten shot. They're there to find that active shooter, contain him, and defuse the situation. So you then have to have that second team when it's safe, and you have to plan out when it would be appropriate within that incident to go and provide medical care. And then, of course, train professionals to address the support and counseling. Things to consider. So having a kit for your law enforcement that contains floor plans, maps, and badges, for example, is helpful. Even if you provide them with tours and work with them on other instances, not all of them will be familiar with your facility. You might want to standardize your entries. By doing this, it allows the ease for law enforcement to move around to find the shooter. If you number them, for instance. When it comes to prisoners, security should know when the prisoners are being moved and where their main base is. Keep in mind that that transporter has no clue that this patient has a violent history unless you found a way to flag it in your system so that all staff are aware. When it comes to prisoners, serve only finger foods, or anyone with a severe violent history. I mean, if you supply utensils, then you better account for them afterwards because they're going to get used against you otherwise. It's important to have alternate areas where you have your incident command center. I mean, it would be terrible should you have an event and a certain part of your organization facility is locked down, and that's where your incident command center is, that's where all your tools are and your supplies, your radios, etc. So you need to have an alternate and make that clear where that would be. And your hospital's not going to stop running because you have an active shooter. If you're a big enough organization, I mean, babies are still going to be born and cardiac arrests are still going to happen, and people still have to be able to treat them. So you got to determine also where off-site emergency areas would be for parking, because people are still going to be coming in for appointments. And you have to find a way to contain them. But obviously if they're in an emergency, you're going to have to allow them to come in. And you have to really think that process through. And create a protocol for crisis management and response. So a lot of times those reporters are going to show up on the off-site area where people are running off to be safe. You need to have somebody stationed there so that they can deal with the media there as well, so that you keep things under control. So those are the types of things you want to consider in an active shooter, and there's many, many more. This is just some highlights for you. And like anything else we do in healthcare, we should be doing root cause analysis. We should do it on every incident resulting in an injury. And those outcomes that would come out of it should identify your high-risk situations and behaviors and develop quality improvement processes for that area. And then look at it on an enterprise risk management approach and see if it applies to other places. And again, if you collaborate the effort between your workplace violence leaders, your risk management, your human resources, and frontline staff, This really, I think, helps show the commitment and accountability by your senior management and administration, and that they care and want to keep their employees safe. So what are some of the consequences? There's penalties. So this particular hospital was fined $4,500 for failing to protect staff. It was a psychiatric therapy session when she was attacked, and the center did not have any prevention measures in place. Other regulatory investigations. So what can happen when you have a violent incident is that multiple agencies are going to come and take a visit, such as OSHA, CMS, your Department of Health. They're going to investigate it. And what I found very interesting was that you may have different violations for each of these agencies, even though they all have to do with workplace violence programs. So the fines and action plans could be very different. You know, you might get fined because you didn't have a standalone written violence program. Another one may say, well, you didn't have controls and prevention strategies in place, and your training requirements weren't good enough. Or, you know, you weren't doing a periodic review of your program. You get the idea. So you need to be prepared. There's going to be a lot of paperwork involved. There's also the liability. We can't forget that part, right? You're liable for negligence because you didn't implement the security plan or provide training. There's going to be workers' compensation claims. There's going to be a lawsuit against the patient. There'll be those third-party witnesses who experience some sort of physical, emotional distress. And, of course, other staff can file workers' comp. So what carriers get placed on notice? All of these could. The active shooter is the kind of thing you hope never happens, but if it does, you want people to be safe. So while active shooter event is unpredictable, the response to it doesn't have to be. The everyday violence that is happening within healthcare organizations on a regular basis can and should be decreased. The cost of the liability and possible lives in the aftermath is far more than the cost to be prepared here. So in conclusion, we really need to anticipate and plan for crisis and serious events because they will occur. It's ridiculous that we've waited this long to develop comprehensive programs for workplace violence to protect those who care for patients with their heart and souls. The way I frame it is this: strategize, prioritize, drill, and then do it again and again and again.